So this year theme is about the kidney health for everyone, and it's about living well with kidney disease. Chronic kidney disease is associated with many symptoms, and its treatment includes medications, a huge number of medications, dietary restrictions, fluid restrictions, and later on the kidney replacement therapy. All these can disrupt and constrain the daily living and impair the overall quality of life of patients and their families. During the past decades, there have been limited improvement in the quality of life of individuals living with chronic kidney disease. And now recent research and practice is increasing in recognition of the need to identify and address patient priorities, values, and goals. The health-related outcomes of quality of life outcomes of the chronic kidney disease should support the chronic kidney disease treatment, the physical function of the patient, physical activity, sleep, fatigue, diet, psychological support for the stress, depression, and cognitive functioning, social support, and the global quality of life, perceived health, daily functioning, happiness and satisfaction, and spirituality. The health-related in this study that was done on 1,700 patients, it's a prospective multinational study for patients with various kidney disease in CKD 3 to 5 and patients on dialysis and transplantation. And they studied the predictors for low quality of life in those patients. And dialysis came first to lower the quality of life of patients. So we cannot, dialysis is a must for a big number of patients. We have to make all the efforts for the prevention from the beginning to delay progression if this is possible, and to give time for the patient to change the modality that is suitable for them. This might change the outcomes and promote for transplantation if this is affordable for the patients. Comorbidities, of course, other comorbidities will add to lowering the quality of life of the patients, being female, lower education, which prevent those patients from having, from understanding more about their disease and from learning how to cope or how to be engaged in this, in their disease process. And having no partner or no caregiver, this also decreases the quality of life, because caregiver has a big role in patients with chronic kidney disease throughout their journey. So recently, the core outcomes has been gaining huge interests, and the core outcomes sets are defined as an agreed standardized set of outcomes that should be reported as a minimum in all clinical trials in specific areas of health or healthcare. Those outcomes may or may not be the primary outcome of the trials, and they should be identified through a consensus process to ensure they are critically important for both the patients and for the healthcare professionals. There are barriers to implement this by trialists, maybe due to lack of awareness about the importance of those core outcomes, resource constraints, as this will add extra cost for the trial, lack of incentives for giving extra work and extra job for the trialists who are working on it, and the complexities in measuring the patient-reported outcomes, which I see the most important one, as it's really very difficult to measure this. So if we look at the patients and the caregivers' priorities for hemodialysis, we find that the patients and the caregivers tend to have a priority for the outcomes that are more relevant to their daily living and well-being, and not just for the numbers and for the data. So implementing, so this is the SONG implementation, which is the report of the standardized outcomes in nephrology, SONG implementation workshop. And in 2015, they found that there are an estimated 14,000 randomized trials that were published in chronic kidney disease. The most frequently reported outcomes are the biochemical endpoints rather than clinical or patient-reported outcomes, including the cardiovascular disease, mortality, and quality of life. So the reports for the SONG in hemodialysis patients, the core outcome, which is the critically important to all stakeholders, all the patients together with their health professionals, we find that fatigue comes as a core outcome together with the cardiovascular disease, the vascular access, and the mortality. And then all other symptoms comes after that. Also for the kidney transplantation, where life participation comes as a core outcome together with the graft health, cardiovascular disease, malignancy, infection, and mortality. Same for the peritoneal dialysis patients, where all stakeholders supported the inclusion of the PD-related infection, cardiovascular disease, mortality, technique, survival, and life participation as the core outcome. So life participation and being well is the main, is the core for all the patients if we take their opinion. During the journey of the chronic kidney disease, the patients passes through many phases, and symptoms management for the pain, for the pruritus, for the fatigue, preservation of the kidney function, slowing the progressions, initiation dialysis, and then also they pass through many. And to be living well with kidney disease, we should stress on the life participation, education, engagement, and empowerment of patients, and address symptoms and life impacts. So we address symptoms like what we have mentioned before, all the symptoms, fatigue, cramps, depression, and the life impacts that those patients, their ability to work, to travel, to study, the financial impact of their disease on their life, the dietary and the lifestyle changes and social activities, and the clinical strategies like what we have mentioned, the preserved kidney function, patient-friendly lifestyle and diet, the pharmacological management, delay dialysis, incremental dialysis, patient-centered dialysis, and preserved kidney function. And then the patient reaches the end stage, kidney disease, and they are confused between the active treatment they are receiving and between the renal replacement therapy that they are going to initiate. And at this stage, there should be special care for those patients and special clearance, low clearance clinics or special clinics should be dealing with those patients and should inform them about all the modalities for the renal replacement therapy, non-biased, and giving them the choice to choose the modality that suits them best. Is it if they have the facility to proceed transplantation, or if they are going to stay on dialysis, is it a hemodialysis or a peritoneal dialysis, and is it going to be at home, or is it going to be at the unit. Nurses and the multidisciplinary education team that should be available in every unit, and they have great role and a very big role with the patients. Doctors don't have time to stay with every patient discussing each and little detail of their life and of their diet and solving their problems. Nurses are a bit closer to the patients, and they should answer the questions that doctors have no time to communicate with. So nurses should help in educating the patient and should help the caregivers. And then we have, of course, the nephrologists with their known role, and dietitians should be involved, and the patient should be referred to dietitians because we give the patients just broad lines, just have a low protein diet, low salt diet, restrict your fluid, and then the patient goes home and they don't know what to eat. Is this considered a high protein or a low protein, or what should I be eating? So the role of dietitian, it's very crucial to make them feel supported and to make them feel in control of what they are doing, and to be eating satisfying them, yet eating correctly. The pharmacists, because all those patients have multiple comorbidities, and they are taking many huge number of medications. The physical therapist to carry out physical assessment for those patients and to create individualized training, supervised training programs for those patients. Expert patients with previous experience, they would give much help, even more than doctors and even more than nurses, than how to deal with the details in their lives. Social workers, because those have very important role, and they have to be available in every unit, because the patients need support, counseling, financial issues, and they should be connecting them to organizations or to foundations where they can support them with the funds, or to support the cost of the medications that they are receiving for erythropoietin or for immunosuppression or for any other medications. Occupational therapists and psychologists, which will have to handle all the problems that those patients are going through. So patient empowerment and partnership, which is defined by the WHO as a process through which people gain greater control over decision or actions affecting their health. And this requires the patients to understand their role and have ability to be engaged with the clinicians in taking decisions that are related to their disease. And even though there's involvement of the patient in the development of the drugs and devices that's related to their treatment. So the suggested strategies for living well with CKD using the strengths-based approach is to build resilience and to provide strategies and resources to manage stress, harness of social connection, facilitate connections with other patients, build awareness and knowledge, facilitate access to support, like we have mentioned before, for dietitians, social workers, mental health professionals, and occupational therapists, establish confidence and control in self-management. Living in a low-income region, this adds to the problem. And many patients present in very late stages with the need for emergency dialysis, probably because there is no specialized facilities that's close to their home. Few fortunate patients undergo kidney transplantation, yet high costs of immunosuppression medications in some countries makes this difficult. And in rural areas, the problem is more magnified than the urban areas, and maybe adapting a telehealth technologies, if feasible, to educate these patients will be of great help. And through the past year, everyone has been using the telecommunication, and it proved to be working, and people managed to be dealing with it easily. But this, of course, has to be organized through the units or through the hospital, not just through WhatsApp, not through the WhatsApp messages. This has to be something formal and organized. And to implement kidney incentives for the health providers who would be adopting those technologies. And this was a single center study for the quality of life in Ghana. And they, as you see, that the low income, anemia and diarrhea in stage 5, they all have significant effects on the quality of life of those patients. Managing anemia is a huge cost for all the patients, as you all know, and it's a burden. And this was a systematic review on the economical cost of the ESAs, but actually with respect to the cost of the ESAs, the non-treated patients and the problems related to anemia entailed higher medical costs and healthcare resource utilization that outweigh the ESA costs. So we have to ensure that those patients are taking their erythropoietins, or as we mentioned, through social workers that have to direct them to foundations or to charity organizations that could support their medications. And here, this is also the holistic approach for people who have multiple comorbidities, for people who are diabetic and with chronic kidney disease and other comorbidities. Those patients have huge number of visits to the hospitals for different reasons. So this the telehealth pilot study concluded that this could reduce the unnecessary clinical activity and reduce the number of visits to the clinic, especially in the COVID situation that we are going through. And of course, this will improve patients. Understanding the holistic experience for the living with kidney transplant. So in transplanted patients, the robust psychological and social support is associated with better survival and medication adherence. And this was a similar study on the well-being and medication adherence in young adults. And in this study, most of them were on dialysis. 70% were on dialysis and 30% on transplanted. And also, well-being and medication adherence were both negatively associated with the psychological morbidity and dialysis treatment in young adults. And recently, they have gone further to engage the patient and the family members to design and implement patient-centered kidney disease research. And in this study, they they recruited the patients and their caregivers as a co-investigators, paid co-investigators, and they provided patients with the research and human subjects training, and the patient participated in monthly meeting, either remotely or in person, and they routinely checked with the patients and solicit patient input on conducting study and dissemination. So this helps the patients to get engaged and also helps the trialists to get with results that are more and more related or more and more affecting the patient's life. And the last thing is the caregivers. And caregivers, a care partner is often an informal caregiver who is also a family member of the patient with chronic kidney disease. Caregivers are very important, and we should give time to educate those relatives or caregivers or care partners, because those help in giving the medications to the patient. They help in transportation, in schedules, in even communication with the medical healthcare about complications, about things that, especially if the patient has any other problems or dementia or whatever. So those caregivers are very, very important, and their role is crucial in the management of those patients. Yet those patients, those caregivers also need the support, because by time they get burnt out and isolated and drained from all the efforts and from all the stress that they have been going through. And especially now in the COVID pandemic, this is a study on the effect on how COVID affects the life of the caregivers or the parents of children with chronic kidney disease. And the COVID-19 outbreak had physical, mental, logistical, and financial impacts on families with children on long-term kidney replacement therapy. And when they discussed the difficulties that they are facing, and they categorized their difficulties with the current difficulties that they are facing at the moment, and the worries of the problems that they can have within the next 2 months. And most of them were suffering from shortage of the masks, from supplies, from getting erythropoietin injection, from having to go to the clinics, hard to have blood tests, whether for dialysis or for transplantation patients. And above this, they have worries regarding the next 2 months and the risk of acquiring COVID-19 even during hospital visits and going to the clinics. So to conclude, the effective strategies to empower patients and their care partners aim to achieve the goal of minimizing the burden of chronic kidney disease-related symptoms to enhance patient satisfaction, health-related quality of life, and life participation. This year, the World Kidney Day theme of living well with kidney disease was chosen to focus on plans and actions toward achieving patient-centered wellness, especially during the COVID-19 pandemic that has overshadowed many activities in 2020. So living well with kidney disease is an uncompromisable goal of kidney foundations, patient groups, and professional societies. And thank you.
Thank you very much, Dr. Dina. A very outstanding presentation. Thank you very, very much.
Thank you.
Dr. Tariq, would you like to comment or?
Yeah, sure. Thank you very much, Dr. Dina. It was really outstanding presentation.
Thank you.
Of what we are talking about this year. Maybe I just like to summarize what you've been saying, which is about the empowerment of patients. You know as much as I do, and maybe all of our colleagues, lots of our patients look to the dialysis therapy or the replacement therapy that's going on is just something to keep them alive until they die. This is a terrible feeling that a lot of patients need really a lot of effort to get rid of. We are not treating patients, we're supposedly not treating patients to give them time until they die, but rather to live a better life. You know, if someone has any congenital defect or has an amputation, he can sit in a chair and cry for the rest of his life, or try to move on with a crutch and keep on living. So this is really a bad feeling that a lot of patients do have, that they are neglected and isolated from the society, and they are always looked upon with pity and empathy. And all of these negative feelings are not doing the patient any good at all. This is what we are here for, and this is what we should be working on for the next year. You mentioned quite clearly that doctors do not always have the time for this type of giving or this type of explanation. And this is something maybe I understand. And you point to the holistic approach and the multidisciplinary approach, which is something really missing in our community. I don't regard Egypt no more as a low-income country. Just we need to organize ourselves, and we should, as Egyptian Society of Nephrology, put this as a target for us, how to make things better, how to have a multidisciplinary approach. The expertise are there. We have the dietitians, we have the psychotherapists, the stakeholders. This is something else. We cannot do this on our own. Definitely impossible. Our voice, our patients' voice, so to speak, has to reach the strategy makers. We have to go on, like Professor Hani said, with awareness all through the year. We have been doing this, as Gamal mentioned. We have to do it more and more. This is one important aspect of dealing with the problem, is still we need more awareness about the disease. And then to focus a little bit on patients' awareness of himself. Not all patients are illiterate anymore. A lot of patients really can comprehend what we are talking about, and they should share in taking decisions, because feeling so neglected and isolated is not doing the patient any good. So why are we treating them? Just to keep them alive until they die? We don't want patients to feel that.
And here comes the role of the nurses and the role of other patients as experts. Exactly. They can understand them more. They can have the time for those patients more than the doctor. And I'm not blaming doctors for not having the time, because they cannot do the job of all the multidisciplinary team together. But the nurse can have more time with the patient. Dietitian, the social worker, everyone has to take out, to do their share in solving those problems and dealing, as we have mentioned, with other patients with the same, who have passed through the same experience. They can talk to the patients who are still newcomers, how to accommodate with dialysis, مثلا going 3 times, how to accommodate with all the restrictions for the diet, how did they manage this? Doctors don't see those fine details, but actually the patients are not aware very much about the PTH or about, but they are minded with those fine details. The patient live those fine, simple details, and those, like we have seen in the core outcomes, is fatigue. Just feeling fatigue all the time is much more important than the bone mineral disease that this patient have. He's feeling fatigue. I cannot perform. I cannot do my physical activity or work or have my social or travel even as I used to be. This is very, very devastating on the long term, and it's not a disease that will be cured in a week or a month or even few months. It's for life. So we have to stress on this part because it's very important. And we have to listen to them, and we have to refer them to psychologists, psychiatrists, and others who have more time or more dedicated job to do this.
So, in simple words, you want help from others, and
Yes.
we start by small steps. I like this point that you just made. Psychotherapy is something very important. It will alleviate a lot of misnotions that the patients suffer from. I think this could be something good. We can start baby steps, as I like to say, just start by that, for example. And I'm not blaming the doctors. Doctors have a lot of pressures and a lot of things to consider, not to mention what is happening with the COVID situation and what it is doing to the healthcare providers, which are us and the nurses and whoever. All of these things are a really big challenge. Thank you so much, Dina, for this wonderful
Thank you, Professor.
overview. Thank you.
Thank you.
Sir May, would you present the next speaker, please?
Who's going to be? Who is